on the various pathways in the basal ganglia. So let's look at some of the key structures in the basal ganglia. The basal ganglia has something known as the striatum, which is formed of the caudate nucleus and the putamen. The putamen and the globus pallidus, internus and externus, form the lentiform nucleus. The internus and the externus are important because the internus will communicate directly with the cortex, actually, from a
through a thalamic projection.
And the externus will communicate bilaterally, actually, back and forth, between a subthalamic nucleus. And also, the substantia nigra will play a role in some of these pathways. So, should we look at some of these pathways? Or do we need to go further into the structure of the basal ganglia?
I think visually conceptualizing the basal ganglia with this striatal loop connecting to the lentiform process, I think that's a really crucial concept to grasp. Because the striatum is the mediator and the bridge between the higher cortex into these deep brain structures. So it's all excitatory inputs from the cortex into the striatum. The striatum then provides inhibitory inputs into the lentiform processes. So there's two pathways here. There's the direct pathway and the indirect pathway. And both of these gauge on the concept of disinhibition. We will explore first through the direct pathway. We will explore the initiation of movement, and then through the indirect pathway, the inhibition of movement. So these two pathways are a parallel, and the interplay between them is what allows for you to start and modulate movements, or to inhibit and slow down movements. So let's start off with the direct pathway. The striatum provides the GABAergic inhibition of the globus pallidus internus and the substantia nigra reticulata. This is the reticular layer of the substantia nigra, loosely packed with your cell bodies of your dopaminergic neurons, and is what will then inhibit the thalamus alongside the globus pallidus internus, which also inhibits the thalamus. We are referring to the anterior nucleus of the thalamus here, which will then provide excitatory feedback back into the cortex, and it's this loop where the cortex will generate a movement or movement pattern. It will run it through the basal ganglia, and the basal ganglia will output again to stimulate the cortex through the direct route. Here, you're able to generate a movement. The voluntary movements you're able to make sure that you're able to initiate them, but there's also an element of rhythmicity here, where you're able to keep cycling through this loop. And you don't need, if you're able to establish synchrony in this loop, you're able to form repetitive movements. This is why you can often see patients in Parkinson's disease with dysfunction in their substantia nigra and degeneration that have inability to really activate their basal ganglia, the direct pathway more so. However, they are still able to perform repetitive tasks such as cycling. However, they would not be able to walk, or they would have really impaired movement and are often presented with a shuffling gait. So on the other side of the picture, we have the indirect pathway. This is your termination of movement. This functions with inhibition from the striatum to the globus pallidus externus, which then would originally be inhibiting the subthalamic nucleus. Now, the concept of this inhibition comes here because the striatum is inhibiting a structure that would originally be inhibiting. So therefore you excite the subthalamic nucleus, which therefore is able to excite the globus pallidus internus and the substantia nigra reticulata, which again, these two structures are inhibiting. So if you're exciting an inhibition, you're inhibiting it more. So the anterior thalamus is inhibited more, and there's less excitation back into the cortex. This is what terminates your movements, slows your movements down.
Can I just add to that? Onto the disinhibition. This is a compartmental model used in system dynamics. And it's essentially showing this concept of disinhibition, where if you have an inhibitory neurotransmitter like GABA, which decreases action potentials, if you inhibit the inhibitory effect, you're essentially just allowing more excitation, so more action potentials to flow. So you can see in this diagram, STRD1 will go into the GPI, and these inhibitions together will cause excitations in areas such as the thalamus and the cortices. And yeah, this is the basic concept of disinhibition. You can carry on with the indirect pathway.
Yeah. So those pathways exist, and they are the two main pathways. Now, there is also a hyperdirect pathway, which is able to bypass all of these, all the basal ganglia structures, and directly project to inhibit the anterior nucleus of the thalamus, and it acts as an emergency brake to stop all movements. That's also been found. I think the other thing that's important to mention is the role of the substantia nigra. This is one of the few key areas in the brain that houses your dopaminergic neurons. This is very densely packed with dopaminergic neurons. There are two parts, the compactor and the reticulata layers. The substantia nigra is named specifically because it's a very dark staining region within the midbrain. So next, I think it's really important to explore the role of the substantia nigra within this pathway. This is one of the key areas of brain that houses your dopaminergic neurons and is evidently seen on brainstem cross sections as a very dark staining region. The substantia nigra has two parts, the substantia nigra compacta and reticularis. The compactor is very compact cell bodies, and the reticulata is more of a loose layer of cell bodies. Each of these has differing functions, and they act to modulate the pathways through the basal ganglia, exciting the direct pathway and inhibiting the indirect pathway. So you're able to generate your movements, you're able to start your rhythmic patterns, things like locomotion, etc., etc. And it's especially a crucial area involved involved in the degenerative pathology of Parkinson's disease, which I'm sure we will explore later in
Yeah. The substantia nigra are also important in the Nigrostriatal pathway. You make reference to that? Okay. So the substantia nigra will release dopamine to have an excitatory effect. Note that dopamine can have an inhibitory effect, even though most people think it's just an excitatory neurotransmitter. It'll have an excitatory effect on the striatum
Yeah, you
into the
have
GPI.
your substantia nigra compactor primarily will provide your excitatory input into the striatum, and basically you'd think it would sequential like together. You'd be both exciting the indirect and the direct pathways. But it comes here because the substantia nigra reticularis is also in this recurrent feedback loop in the direct pathway. So you have these two pathways for inhibition of the SNR and the GPI to then excite the thalamus, and then you only have one pathway for the indirect, which means that there is more excitation, there's more drive for the direct pathway to initiate your movements.
Yeah. This model nicely shows that, the inhibition which excites the thalamus and the cortex. Now, just a few additional notes for the nigrostriatal pathway. If you want to look at more like the in-depth, from the striatum actually, the striatum will release GABA in the nigrostriatal pathway in particular, which is an inhibitory neurotransmitter. Now, the next signal in the GPE will be inhibited. So, once again, if you release less GABA, you allow there to be an excitatory effect on the cortex, which is very important. Now, why do you need, as this model shows, these complex inhibition, disinhibition, excitation? Why do you need all that? Well, if you had only excitation, what would happen is the effects of one stimulation would be amplified to such a degree that everything would be completely chaotic in the brain and throughout the nervous system. And if you add a simple inhibition, this would also amplify across the entire nervous system. You need these complex loops using disinhibition and excitation to essentially modulate these responses to make sure nothing is out of control and to maintain the integrity of action potentials. And if you have any damage to this, many disorders can arise. Maybe you can mention some.
Parkinson's is
Parkinson's.
the key pathology here.
Seizures?
Not particularly.
Okay. It's interesting. Okay.
Yeah, seizures can present throughout the cortex with focal or general.
Okay.
So theoretically, maybe, but very uncommon. Because this area of the brain is involved in more modulatory effects on your movements. So yeah. But no, without a doubt, you can have excessive firing of things like the subthalamic nucleus, especially in Parkinson's, where you're using deep brain stimulation to electrically induce either increased or decreased firing, so you can alter the rhythmicity of the subthalamic nucleus and disrupt the indirect pathway to alleviate some of the motor symptoms, things like tremors, etc., that are common and arise from the pathology of Parkinson's. So that's so cool because the whole motor system, especially the basal ganglia, has many connections and feedback loops. Now, these are very finely tuned and have evolved for the efficiency of the motor system, for you to be able to control in space and time your limbs and all your movements to a very precise nature. So the basal ganglia has a lot of connections. There's a lot passing through it because it needs to modulate primarily your corticospinal tracts. These are the ones that will, especially for humans, are going to directly innervate your lower motor neurons, your alpha motor neurons, to perform your final contractions. And yeah, so there's a lot of input that needs to run through the basal ganglia. The cerebellum will take all your proprioceptive information, all your position in space and time, all this coordinating the body within space and the extent of muscular contraction will all run into the basal ganglia. Higher cortical regions, limbic inputs, so your emotional state can have a really big impact on your ability to generate or stop movements. Your motivation levels, again, very big impact on your movements, and especially with interacting with the primary motor cortex, because it is your primary motor cortex, your somatus, your SMA, your premotor cortex, that are primarily interacting with the basal ganglia. It's the SMA in particular that has a lot of your basal ganglia. So the basal ganglia and the whole motor system is finely tuned to perform precise and efficient movements. So the modulation of whether you stop movements, and you're controlling your movements in a dynamic nature through the basal ganglia needs a lot of inputs and has a lot of outputs. The primary loops in this circuit arise between the primary motor cortex and the premotor areas. So your premotor cortex and your supplementary motor area. These regions take in your higher processes. So integrating parietal lobe sensory inputs. Proprioception from the cerebellum goes straight into the basal ganglia. So all the coordination required to perform movements. Limbic inputs, which take in your emotional state, affect your ability to generate or inhibit movements. It's probably why you often get freezing of People literally freeze up and cannot generate movements in high stress situations from great amounts of fear. So you can see how the connections between the cortex, cerebellum, and also the spinal cord. You have your deep motor nuclei within your spinal cord, the midbrain, the brainstem in general. They can also have inputs from the basal ganglia to control the output and outflow of movement, and also inputs as well from ascending sensory pathways. Knowing your location in space and time, especially, is very important.
Yep. You can see here all the interactions here with the thalamus, the limbic system. So the limbic system takes sensory, motor inputs primarily, and the limbic system actually has gyruses like the parahippocampal gyrus and the cingulate gyrus, and it's very important in these pathways with the basal ganglia. The limbic system also forms a Pepez
circuit.
Is that involved in the basal ganglia as well?
And there's an important distinction to make.
Okay.
Is that the basal ganglia's function is primarily movement. Basal ganglia is part of the diencephalon. So these are your rudimentary brainstem structures. I think it's a key distinction to make because we don't want to blur the lines between emotional states and movements, because there is overlap, but they are two distinct circuits that have both evolved as very rudimentary structures of the brain, but have very important functions.
Would you say that the limbic system is far more complex in that regard because it deals mainly with emotions rather than crude movement?
The thing about movement is, if it wasn't for movement, we'd literally be plants. Plants do not move. So movement is literally the basis of human nature and human life. So you say movements are crude in this sense, and you kind of take them for granted because you think that emotional states and emotional processing has very high cognitive value and higher functions required to do that. But there is so many elements in making a movement fine, controlled, specific, that you just cannot get to the same extent. And that's why the motor system is so complex. Even just performing a simple nose to finger test, if there is pathology in your vestibular, in your
To do with balance?
yeah, in your proprioception, in your knowledge of space and time, and your cerebellum as well, that smoothness of that movement, to be able to contract the agonists, relax the antagonists, and move in such a fine way is very complicated. So I think they're both in a different context. Each are more important and developed specifically for their function.
Okay, thank you. Now, should we get into the meat?
I think you should. Let's get into the meat. So let's explore, because so the whole motor system, especially the basal ganglia, has many connections and feedback loops. Now, these are very finely tuned and have evolved for the efficiency of the motor system, for you to be able to control in space and time your limbs and all your movements to a very precise nature.
Now, let's get into the patient cases. A 65-year-old man presents to the clinic with progressive difficulty initiating movement, resting tremor, and shuffling gait over the past 3 years. His wife reports that he has become slower in daily activities and that his handwriting has become smaller. He also describes loss of smell, olfaction, primary olfactory cortex could be affected in temporal lobe.
Yeah, anosmia is kind of a prerequisite, very early sign of onset of Parkinson's later in life, actually.
And occasional vivid dreams with movements during sleep. Past medical history: hypertension, hyperlipidemia, and mild cognitive complaints. Medications: amlodipine and atorvastatin. These are very commonly used. Even I use them in private practice. They can be used to treat 2 or 3 conditions. No family history of significance. He is a retired construction worker. Now that screams motor deficits. Physical exam, neurological exam, bradykinesia, resting rolling tremor, 4 to 6 hertz, shuffling gait with decreased arm swing, postural instability noted on the pull test. Now let's get into the lab tests. Normal CBC, CMP, and TSH, thyroid stimulating hormone. Neuroimaging, MRI brain, mild age-related atrophy, no acute pathology. This patient's symptoms are caused by degeneration of which structure now? So what is your thought process going into this? What really sticks out to you?
I think you've said every single possible characteristic of Parkinson's disease there.
Okay, like what?
This would be the dopaminergic neurons in the substantia nigra having degenerated. And that is what you would cause a lot of your motor deficits. So what arises in your postural instability, tremors, rigidity, some of your key standout features. Of course, there are many more. The anosmia is a sign that can be a precursor to developing Parkinson's disease later in the future. Yeah, the bradykinesia, slowness in the movements, because
Bradykinesia also.
slowness in the movements,
Any particular movements?
and decreased ability in initiating movement, so less movements in general. You have your characteristic shuffling gait and your pill rolling tremor.
Oh, you said decreased ability to initiate movement, so that would be affecting the direct pathway.
Yes, in this case, you have degeneration of the substantia nigra, and the balance between direct pathway activation and indirect pathway activation is kind of put in the balance. Is dysregulated, so you have more indirect pathway activation than direct pathway activation, which is what results in your decreased ability to initiate your movements and your bradykinesia primarily, postural instability, and all these other symptoms that come. Now, I think I'm gonna bring in a key case for you as well. So, a 40-year-old woman presents with voluntary movements, which are progressively worsened over the past few years, 6 months in particular. Her husband knows personality changes, including irritability and impulsivity, difficulty in maintaining memories and decision making, and her father experienced similar symptoms in his early 50s. Past medical history involves depression, anxiety, currently on sertraline. Her father had a progressive neurological disorder, but never received a definitive diagnosis. School teacher, no alcohol, no drug use. Physical exam shows choreiform movements of the face and extremities, impaired saccadic eye movements, impaired executive function, difficulty with recall is seen with her cognitive symptoms, and her motor exam shows hypotonia and an unsteady gait. Every test come back normal. CAG trinucleotide repeat expansion in the HTT gene, Huntington gene, shows more than 40 repeats. And finally, the neuroimaging shows atrophy of the caudate nucleus and putamen and enlarged lateral ventricles. So, discuss a little bit about what you think is going on here, what are the key standout features, and how you would go about dealing with this patient.
So even before we got to the 100% determinant of what this is, you can already hear that this is involuntary movement that have been progressing over time.
Or hyperkinesia.
And this shows a degeneration. And just as the husband reported, that there's been personality shifts as well, we can see that something's being affected over time in a gradual process here, which is very telling of Huntington's disease. And we can also see it's genetically linked because the father suffered through a similar process, not just a single action, a process, which caused many manifestations. And then finally, the trinucleotide repeats in CAG. The normal level is actually 27, and as you increase this, you can become a carrier. And then if you get to a certain threshold, 40 is way above that threshold, you become someone
30
above 30,
CAG trinucleotide repeats in the Huntington gene.
where you express the gene and you have Huntington's disease. So this would affect the
Excitatory inputs from from the generation of striatal cells. Um,
And it was also the effect the direct pathway and the indirect pathway as well.
yeah, so it comes about with your striatum excessively activating your direct pathway and compared to your indirect pathway. It's the opposite. Parkinson's disease, you have hyperkinesia because your direct pathway is constantly looping back to your cortex, so you're generating a lot of movements. So it's what you cause your characteristic choreiform facial movements, your hyperkinesia, so excessive jerky movements, and also um, affects broader cognitive systems as well, impairs the hippocampus and transynaptic circuits, limbic projections into the pairs circuit. So you get changes in behavior, impulsivity, problems with memory, learning, things like that as well.
Okay, yeah. And if you have problems in these pathways, then not only are you gonna, in this case, they struggle to control involuntary movements, which is the case if you can't inhibit certain movements. And very telling of a 19-year-old man presents with progressive clumsiness, tremors, and difficulty speaking for the past 6 months. He has also experienced mood swings, irritability, and trouble concentrating in school. His parents say he has been more socially withdrawn and has difficulty with daily tasks. Daily tasks. Past medical history, none. Medications, none. Family history, no known. Neurological or liver diseases. Okay. Now, when you're looking at some of these questions, you're thinking, okay, especially in the USMLE, why have they mentioned that specifically? No liver diseases. How could that affect it? Let's see. Social history, college student, no alcohol or drug use, neurological exam, dystonia, resting and intention tremor, dysarthria, ophthalmologic exam, golden brown ring around the cornea, motor exam, rigidity, bradykinesia, difficulty with fine motor movements. Fine motor movements to do with the medial lemniscus. Lab tests, serum ceruloplasmin comes back low, serum copper low, 24-hour urine copper increased. There we go. That's very telling. Liver function tests, elevated AST, ALT, genetic testing, ATB78 mutation, neuroimaging, T2 hypertensities in the basal ganglia. Now, which of the following is the best initial treatment for this patient? So first of all, let's look at the diagnosis. What's your process and thinking?
The first thing that stood out to me was the fact that there were golden brown rings around the cornea. Now, these are known as Kaiser Fleischer rings, and they are from copper deposits. And later on, you mentioned all the effects of um, all the urine, copper being elevated. So, normal liver function. However, this does this does resonate with Wilson's disease, where you have buildup of copper deposits, not necessarily high copper in the serum, but mainly deposits within tissues, and you can get deposits in within the basal ganglia. And what this can cause is these copper deposits are basically forming as kind of plaques or act in a similar way that result in neuroinflammatory mechanisms and neurodegeneration. So you can see this is an onset over a period of time, 6 months in this case. And and Wilson's disease has been linked with ATP7B gene mutation as well. And so I think it's very important that we note how Wilson's disease actually affects the basal ganglia. You can see the rigidity, bradykinesia, and difficulty with fine and motor movements. Similar presentation as with Parkinson's. So you have decreased activation of your direct pathway, increased activation of your involuntary pathway, and you get these kinds of symptoms. However, it's in a different context, and there is some differences. So you have your hypotonia, you have your dystonia, and you have essential resting or intention tremor, which is a little bit different to your tremors. So